Hello everyone, and welcome to this overview. This overview in on the importance of reduced nephrotoxic immunosuppression in pediatric renal recipients. This is an overview aligned to the World Nephrology Congress, or WNC 2023, and this presentation is on behalf of the Renal Patient Support Group, the RPSG, So to begin with, the presentation outline is as thus. So there'll be an introduction, a look at some historical aspects of transplantation or transplant medicine. A look at sort of transplant immunobiology. Look at the MHC, major histocompatibility complex, MHC, and HLA, human leukocyte antigens. Look at sort of immunological tolerance. A look at immunosuppression, sort of more specifically, and then I look at sort of immunosuppression categories, and then I look at sort of interleukin-2 receptor antibodies, monoclonal antibodies, calcineurin inhibitors, an overview in linking immunosuppression and pharmacology. I look at biomarkers, and looking at sort of comprehending drug-induced nephrotoxicity, and a critique of laboratory medicine, and then as part of this presentation, I look at getting sort of the toxicology right, and then I look at a summary as part of this presentation. So to begin with, an introduction. So by the end of the mid-90s, around 1995, over 250 patients with end-stage renal disease, or ESRD, were alive in the United States. The number of new patients undergoing end-stage renal disease modalities have continued to increase at a rate of around just under 10%, around 7% to 10% a year or per year. Although not all ESRD recipients are eligible for renal transplantation, from mid-90s towards the sort of end part of the 90s, nearly 37,000 recipients or patients were registered for possible renal transplantation. Over 54,000 people had been on the total waiting list for all organs, for all organs. However, in '96, only 11,099 renal transplants were performed, and specifically just over 3,389, and specifically from live donors, and from all the various solid organ transplants. A disparity remains between the number of patients waiting for transplants and the availability of suitable organs. Towards the new millennium, around again the latter parts of the 90s, there were 3,900 patients waiting for cardiac transplants, and 2,700 for for lung transplants, 235 for heart and lung transplants, 9,600 for a liver transplant, and 92 for an intestinal transplant. In 1996, 2,340 cardiac and 805 lung, and 39 heart and lung, and 4,000 liver transplants were performed. Owing to the increased experience and advances in surgical techniques, tissue preservation and post-transplantation care, including immunosuppression, the overall success rate or prognosis of transplantation had been improving. It was in the late 1980s, the one-year graft prognosis rate and using or utilizing cadaveric grafts, cadaveric allografts was just under 80%, but by the mid-90s, the one-year cadaveric allografts of prognosis increased from around 76% to just under 90%. And results of renal transplantation from living donors also improved from just under 90% in 1998 to 93% in 1995, the mid-90s. And with the increases in prognoses, more patients experience better outcomes. So in around the transplant immunobiology, so unlike other solid organ transplants, renal pathophysiology consisted of ABO implied antigens articulated on endothelial cells of blood vessels. Thus, if a donor recipient had different blood group complex from a recipient, the antibodies would result in a type 2 hypersensitivity reaction in the renal allograft, thus causing elimination of transplant through cytotoxic T cell, and specifically CD8 in MHC, the major histocompatibility complex. At the same time, allografted recipients might also have some human leukocyte antigen or HLA through rejection of a preceding allograft, and this implies in more so in those pediatric patients or recipients that have had more than one transplant. So as with many other diseases or conditions, there have been significant immunopathogenic element, and a variety of renal illnesses, renal conditions have associations with the MHC. The first of these was sort of illustrated and associated among the DR2 and anti-glomerular basement membrane. Subsequently, several MHC alleles have been coupled with a variety of other renal diseases. Immunobiology for MHC typing are advancing and rapidly from serological to molecular-based methodologies. In complement to the MHC, several genetic indicators that may be linked with a variety of renal diseases or conditions have been investigated, but also solely for research intrigue. In around the MHC and HLA specifically, so the MHC is used as a basis for all solid organ transplants, and is thus of an underpinning immunology and immunobiology laboratory investigations. Recognition of antigen and T cell receptors requires MHC on the surface of antigen presenting cells. The APCs internalize large antigens, degrade them into small peptide fragments, pair up the fragments with MHC molecules, and then export the antigenic peptide MHC complexes to surfaces where molecules interact with cells. Specifically, class 1 antigens are present on the surface of most nucleated cells, whilst class 2 antigens are less broadly expressed, The DR is equivalent to the D loci or locus on HLA. So in around immunological tolerance, so scientists and laboratory specialists have been investigating transplant tolerance for several decades to improve the acceptance of tissue and cross-match solid organ transplants. And self-tolerance can be partly explained by the destruction of self-tissue by T cells and that react to self-antigens. However, some self-reactive T cells slip through the destruction process, destroying host pathophysiology. And convinced that an antigen-specific mechanism of tolerance exists, works from as early in the early parts of the millennium, or the new millennium, from a team in the University of Washington and also in Rome, began looking for and identified a different set of T cells. These suppressor T cells, or these suppressor T cells, or these T cells were induced, or had induced tolerance after recognizing the antigens on surface of immune cells called dendritic cells, which process and present antigens. Somehow, after the recognition, this T cell suppressor cell robs the dendritic cell's ability to activate T cell and T killer cells to respond to the same antigen. And so without active T helper and T killer cells, the immune response to antigen is put on hold. At the same time, it was looking at the outcome of 16 cardiac transplanted recipients. The team investigators had identified two proteins that play a role in vivo. The team had informed that 5 out of 6 patients who had T suppressor cells capable of suppressing donor dendritic cells, wherein there was no evidence around acute allograft rejection episodes. 9 other patients could not suppress the dendritic cells, and all 9 experienced 2 or 3 AAR episodes. The team from the early 2000s ultimately identified that if dendritic cells could be suppressed, recipients may have a lower probable risk of AAR. So now looking on sort of immunosuppression, or IST. So transplant pharmacology advances as new immunosuppression agents are investigated and approved for use. Clinical immunosuppression has been plagued, however, with maintaining a balance between the rejection of transplanted organs and complications of over-immunosuppression, including infection and malignancy. Whilst all transplant recipients are prescribed some form of IST, the combinations and the choices has increased as new pharmacotherapies are trialed and developed. The foundation of maintenance therapy rests on has rested on the combining of IST to preclude rejection through a variety of pathways. An understanding of the mechanism of action and additive effects of pharmacotherapy allows professionals to optimize therapies whilst decreasing adverse effects. IST offers potential for reducing detrimental patient outcomes and improving allograft prognoses. The challenges facing researchers, investigators, and clinicians focus on improving outcomes and constraints and the constraints surrounding transplantation. So during the past decade, several new potent immunosuppressive agents with different modes of action and different side effect profiles have become available. And nowadays, IST after renal transplantation is no longer a sort of a one single regimen applicable to all patients or recipients. In the selection of the optimal immunosuppressive protocol, individual drug related toxicity, recipient related risk factors, as well as donor organ characteristics have been taken into account. A narrow therapeutic index unique to each recipient, as well as variable absorption, distribution, and elimination, are characteristics of these ISTs. Therapeutic drug monitoring, or TDM, plays an important role in maintaining blood and plasma levels of IST within respective laboratory reference ranges. Variations in concentrations outside the narrow therapeutic ranges can result in adverse clinical outcomes. A TDM of IST has been based on several choices of assay and biological fluid, for example, whole blood and plasma, appropriate for a particular drug. TDM of FK506, for example, has been improved. Has been improved in development of assays and greater sensitivity, along with laboratory assays and greater sensitivity and specificity. So in around the sort of IST categories, there are mainly four main categories. You have your calcineurin inhibitors, you have your anti-metabolites, you have your corticosteroids, and then you have your sort of MTOR inhibitors. So under the types of category, drug category, or IST pharmacotherapies, you have your brand. There's the brand names, and the brand names, and then there's the generic names. So, for example, cyclosporine, historically as referred to as CSA, the brand name was either Sandomune or Neural, both from Novartis, and then there was Dexamune, which was IST by Dexel, and there was Capmune from Mylan, and tacrolimus or FK506, known as was also available from was produced by Prograph and Adograph and Modigraph, which were all produced by Astellas, and then there's Adaport from Sandoz, and there's Tasni or Tacni from Teva, and there was Vivadex by from Dex, and then there was Mylan. There was a Mylan tacrolimus formulation by Mylan, from Mylan. And in around the sort of anti-metabolites, there's been azathioprine, there's been mycophenolate mofetil or MMF by Cellcept, mycophenolate mofetil or Cellcept by Roche, along with several generic brands, along with several other generic brands such as mycophenolate sodium or MMS, and mycofortic by Novartis. In around the in around the corticosteroids, they're prednisolone, which has been generally been sort of non-branded. And then there's the MTOR inhibitors, the sort of mammalian target of rapamycin. Sirolimus or Rapamune by Wyeth is an MTOR. MTOR is a protein related to the growth, related to cell growth, and the maintenance regime is tailored to each recipient. So in around the IL-2 receptor antibodies or monoclonal antibodies, so basiliximab and daclizumab were sort of the first two initial interleukin-2 receptor antibodies, monoclonal antibodies that were licensed in the UK for the use at the time of transplantation. The monoclonal antibodies are traditionally administered before surgery, and they exert immunosuppressive effect only over the first few weeks post-transplant. Both basiliximab and daclizumab have been licensed for the use in combination with CSA and steroidal treatment, which then form a baseline therapy. Both monoclonal antibodies work by inhibiting specifically two part of the interleukin-2 receptor that is only expressed on activated T lymphocytes. So those T lymphocytes that are propagated or sort of lined to elicit to prompt a response against the transplanted organ. Inactivated interleukin-2 helps to prevent proliferation of antigen stimulated T cells. So now in around sort of calcineurin inhibitors, sort of the main sort of ISTs. CSA, cyclosporine tacrolimus or tacrolimus, are calcineurin inhibitors that work early in T cell activation, and T cell activation involves sort of a series of cascades and the enzyme in calcineurin is one of the rate limiting points. Calcineurin is a target of both CSA and FK506 complexes, but which sort of prevent transcription of the genes encoding interleukin-2 and other cytokines that cause early T cell activation. CSA binds to an immunophilin, a cytoplasmic protein called cyclophilin A. FK506 or tacrolimus binds to another class of immunophilins known as FK binding proteins or FKBP, specifically FKBP12, and where CSA, FK506, and rapamune or sirolimus are metabolized in the liver through cytochrome P450 pathway, specifically the cytochrome P450 and 3A4 isoenzyme. And so doses of CSA used vary according to local practice. However, a typical initial oral dose would be or had been evidenced as around 4 milligrams per kilo twice a day, and doses are adjusted according to pre-dose trough or whole blood concentrations. After 6 months or so, target ranges or laboratory reference ranges are reduced to aim for lower sort of mainstay immunosuppression therapy or mainstay maintenance therapy. So in around sort of the sort of pharmacological aspects, more specifically around IST, whereas in a previous slide there was the varying IST, various IST sort of categories. In this overview, there's in around the pharmacology, looking at sort of the regimens and also sort of the sort of regimens in context of being primary regimens, and then the novel regimens, which will not be used or not utilized in practice, in clinical practice as mainstay, but are utilized as pharmacotherapies in particular cases. So the primary regimens, you have tacrolimus, FK506 or cyclosporin A, CSA, aka also known as soraneural, and mycophenolate mofetil MMF as primary, although mycophenolate MMF has been utilized as a sort of secondary since its pharmacokinetic profile on its own as a primary IST does not in the majority of transplanted recipients does not serve as an adequate IST owing to its toxicological profile and its basis as a sort of a potent immunosuppressive agent. However, has been categorized in context of as a primary immunosuppressive agent. And then secondary and tertiary immunosuppression includes sirolimus or rapamycin or rapamune, and corticosteroids, which are used as inflammatory or utilized to reduce inflammation in around transplanted recipients, and azathioprine, which has been used as again sort of a historical is used or has been used as a historical immunosuppression form of immunosuppression therapy in as secondary or tertiary, alongside with either tacrolimus or CSA or MMF. And in some cases, in some documented cases, there's been a sort of comparisons between the utilization of MMF and azathioprine alongside as secondary or tertiary agents with a primary agent, thus CSA and tacrolimus, and so thus azathioprine and mycophenolate in sort of practices, in parts of clinical practice today would not be utilized together. So then you have novel regimens such as novel regimens, but at the same time not particularly recent, are monoclonal antibodies such as basimiliximab and daclizumab. There's also been investigations in the use of SDZ-RAD or RAD, which is a derivative of sirolimus, and then there's been FTY720, an antibody preparation, and then there's been some evidence around beta-leticept, which is a derivative of the CTLA-41G sort of pathway or component. So now looking at sort of delving into a little bit around the biomarkers, since alongside with immunosuppression, which is utilized in recipients of transplanted organs, biomarkers are used on two bases primarily. On one basis are utilized as a use for as a use for detecting renal damage or renal insufficiency. But then at the same time, biomarkers are also used to help clinicians dose accordingly the appropriate immunosuppression. So this overview, sort of the sort of biomarkers that are sort of available, that have been available but are not necessarily or utilized in dare I say it in the correct way. We know for a long time, for example, creatinine or serum creatinine has been sort of the basis of use for detecting renal insufficiency, but there have been works about its use in some regard in amongst certain kinds and types of patients with particular sort of particular renal or nephrological etiologies or pathophysiology. Then there's cystatin C, which has been evidenced in the use of detecting renal insufficiency without the regard or the necessity, if you like, of looking at sort of other particular parameters which have historically been important in for example detecting renal insufficiency. There's also a biomarker referred to as nucleated gelatinase associated lipocalin, or NGAL. And then there's more recently there's been the biomarker FGF23, sort of the fibroblast growth factor 23, which is a biomarker primarily utilized in cardiac recipients, or those who might, for example, those recipients with cardiology sort of etiologies, and then there's a mineral bone disease, looking at mineral bone disease, or MBD, and then one of the main sort of conundrums or the dilemma is that the number of people with multiple long-term conditions, known as again sort of as multimorbidities, has increased from 1.9 million to in 2008 to 2.9 million in 2018, and the increase and need for a varying sort of renal biomarkers has now become greater or more important since creatinine historically has been used and relies on sort of muscle, looking at sort of muscle breakdown in patients or recipients, muscle breakdown in recipients to identify to give and identify the appropriate renal insufficiency and linked to estimated glomerular filtration rate. Cystatin C is a cysteine protease inhibitor that is produced by nearly all human cells. The serum level of cystatin C, however, is a stronger predictor of renal outcome than the risk of cardiovascular events than creatinine alone. However, it is unclear to some extent whether serum cystatin C is associated with signs of vascular dysfunction, such as those that vascular dysfunction that's linked with specific forms of renal disease. Then with nucleated gelatinase associated lipocalin, has been evaluated as a biomarker in specifically around acute kidney injury, and earlier studies with cystatin C also have been with acute kidney injury, in the transplanted kidney or renal setting, and biopsies of kidneys have revealed a significant correlation between NGAL staining intensity and the subsequent development of delayed graft function, or DGF. Urine NGAL concentration in samples collected on the day of transplant clearly identified that cadaveric recipients who subsequently developed delayed or DGF. DGF also subsequently required to be placed on a form of a renal replacement therapy modality. FGF23, fibroblast growth factor 23, is a bone derived sort of hormone that plays an important role in vitamin D metabolism to some extent. And then FGF23 principally acts in the kidney to induce urinary phosphate excretion and suppresses vitamin D synthesis, and this can help determine renal function through parameters that have been specific to MBD, or mineral bone disease. And so, despite in around MBD, mineral bone disease, despite metabolic improvements following renal transplantation, transplanted recipients still have and can suffer from complex mineral and bone disease pathologies. So now, sort of comprehending sort of drug-induced nephrotoxicity. So the early investigation surrounding transplantation led to attempts to understanding the led to attempts to understanding of renal immunology. Unfortunately, however, what has been realized was that no effective IST agents at the time have achieved a sort of a desired effect. Thus where transplanted recipients would be administered IST, or prescribed or administered IST. However, at the same time, there would be the probability, owing to the toxicological profile of IST, could also, owing to the potency, cause a compromise to the transplanted organ. So the first attempts at immunosuppression involved total body irradiation. Although irradiation prevented transplant rejection, this caused aplasia, which had been responsible for a high mortality rate. Anti-neoplastic drugs such as methotrexate and cyclophosphamide were used or utilized for IST, but these agents proved to be toxic and were associated with poor patient outcomes. Going back even further, to some extent, I suppose, is that in the 1960s, prednisolone, a corticosteroid, was utilized to control severe episodes of rejection. Subsequently, 6 mercaptopurine and as sort of prednisolone's or the corticosteroids sort of successor, at least in some contexts, azathioprine were tested successfully in transplantation investigations involving canines carried out conducted by involving canines and carried out by investigations by Roy Kahn and were introduced into clinical practice. Eventually, azathioprine and steroids as a prednisolone were utilized as combination therapy. However, despite some successes, the rate of early graft rejection or early graft failure was high in renal transplanted recipients, and only a handful of kidneys functioned longer than 1 year. Most of the successful cases involve allografts, again allografts from live related donors, owing to from a laboratory and serology perspective, owing to the owing to the um, the uh, the owing to the link between on the one side tissue typing, but also in line to where in live donors in live donors versus cadaveric donors, there is the sort of the ischemic time to think about. And so in early investigations, live related donors had been sort of evidence as where there had been successful cases. So in around the critique of laboratory medicine, the renal biomarkers NGAL and cystatin C have emerged as potentially useful indicators of GFR, glomerular filtration rate, with the latter postulated as a sort of a gold standard. NGAL, as sort of mentioned, alluded to, but also to highlight here, is a 25 kilodalton protein bound to gelatinase originally identified from neutrophils, which is also expressed at low levels in several tissues, including the kidneys, and is released systematically in response to renal epithelial damage or produced locally in renal tubules. NGAL undergoes glomerular filtration followed by tubular uptake, and is one of the earliest and most strongly sort of induced proteins in the kidneys after ischemic or nephrotoxic injury in animals. At the same time, NGAL can be easily detected in blood and urine post-transplant. Hence, it is emerging, or has been emerging as a major predictive biomarker with potential use in risk stratification of EGFR and CKD progression and IST monitoring and IST monitoring in around transplant rejection. So getting the toxicology right, the pharmacokinetics of IST, CSA, FK506, MMF, and sirolimus, rapamycin, aka rapamycin, are complex and can be or are sort of unpredictable. It is also important to identify specific pharmacokinetic and parameter for each individual drug, whether it is trough levels or area under the time curve, which may be most useful for optimal therapeutic drug monitoring in clinical practice. IST concentration should be at minimum level, and a thorough justification for the choice of the immunosuppression that is used. So in sort of summary, direct nephrotoxins, gentamicin, non-steroidal anti-inflammatory medications, rifampicin, paracetamol, or acetaminophen, contrast media, including radiopaque substances, carbon tetrachloride, and ethyl glycol, are sort of the main direct nephrotoxins, and are used in some ways or forms are used in some ways or forms in cases. For example, paracetamol, acetaminophen is is a nephrotoxin, but is used. But transplanted recipients of ovarian transplant recipients, solid organ transplant recipients may use acetaminophen. So different different IST efficacy and safety profile can have a toxicological impact in pediatric recipients, also depending upon disease etiologies and pathology. It remains a challenge to establish peak IST therapeutic dosing. Newer IST and are sort of designed with the objective lowering regimen or doses, which also reduce nephrotoxicity whilst maintaining potency. At the same time, however, crisis one of the main points here is, however, more crisis exists regarding the immunohematology and immunogenetics, where serology surrounding transplantation for pediatric recipients have been launched into as a factor with IST immunosuppression to prompt prognoses. TDM, or therapeutic drug monitoring, should ensure concentrations are not too high or not too low, thereby reducing the risks of toxicity and increasing AAR. Donor-specific antigens remains an issue amongst pediatric recipients, specifically deeper understanding of the pathophysiological mechanisms and the development of novel compounds regarding humoral response are of intrigue to improve transplant outcomes. And the work this work sort of encourages prospective systematic review surrounding the importance of reduced nephrotoxic IST immunosuppression in pediatric renal recipients. That also includes the link with comparing application of appropriate biomarkers. Here is a list of references. Should anyone going through this would like to refer to, and some acknowledgements on this slide, and some special dedications on this slide. Thank you.